Okay. So I believe Jess is going to be presenting on the posterior portion of the hip. Okay.
Yeah. And I just sent you the worksheet for it that I made. There's like 2 separate pages because I couldn't get them to go on the same page.
Okay.
So like there's 2 pages for worksheet, and I sent you the PowerPoint a minute ago because I just got home from the gym. So I sent it as soon as I got home.
Okay. You want me to pull up your PowerPoint?
Or I can, either one.
You can do it if you want. That way you can click through on your own, on
Okay.
your own pace.
Okay.
Yeah, you should be able to, I believe, open it.
All right. Can you guys see it?
Yep.
Okay. So yeah, I'm doing the hip joint, the posterior section of it. And then just a little side note, I tried to get all my pictures to be on the right side of the hip, so it's easier to like keep straight in your head like you should. And then when you're looking at the hip, to start with, it's easy to figure out if you're looking at the front or the back. By if you can see it on the front side, you'll see like a circle, and like you'll see the more of the front of the socket, you still see like 2 circles almost touching like a figure right here. But on the back, it's more like closed off. That's how you know you're looking at the back. And then some bony landmarks and important things that you're gonna need to know for my presentation that'll make sense. Ischial tuberosity, right here, there's a lot of origins from here. This is like your bleacher butt, like if you sit down for too long, then that gets pretty sore pretty quick. And then I'm gonna pronounce a lot of these wrong as well, but we're gonna try here. The linea ischiera is on this part here of your femur. It's like this line thing that comes down this side here. A lot of origins from here. And then pectineal line, that's also just like a little bit area of that here as well. Ilium is just this flat part in here. There's a lot of like the butt muscles there, a lot of them attach in here, just this flat part in here. The acetabular rim is this part here where the head of the femur sits, so the pelvic part, but it's like the little cup part that it sits in. And then the intercaratic crest is this part here, so like between the greater trochanter and the head of the femur, so this little curve here. And then some other bony landmarks that are pretty important are the iliac crest, like top here, the superior part of the hip. The iliac spine, there's a posterior and an anterior part. So the posterior part is here, and the anterior part you can't see, but it'll be on the back side over here. Can you guys see my mouse moving even?
Yep.
Okay, okay. And then the ischial spine is this part here. All right, so the first group of muscles we're going to talk about are the hamstrings. So there's actually 3 of them. Biceps femoris. Those are the ones I cannot pronounce that start with an S that are right here. And they all originate, like something they have in common is they all originate from the ischial tuberosity, so that very bottom part of the pelvis. And then they attach to the hip and the knee joints. But since I'm focusing on the hip, I won't really go into the knee part, but they do help with flexion of the knee joint. Okay, so for the first one here, biceps femoris, this one is going to be the one that's most lateral on the leg of the 3. So it attaches at the ischial tuberosity on this, the bottom part, like I said earlier, and then the second part of the muscle also attaches at the linea ischiera. And there are 2 parts of this muscle, so it's like the biceps femoris, so bi meaning 2, so there's 2 heads of it, so here and here. And then they both come together and they insert at the head of the fibula, so down here under the knee. And this mainly helps with extension and stabilization of the hip joint. Some things to help you remember this, the name of this and where it's at. The biceps, it has 2 heads and it's the most lateral. Next up is tendinous,
Semitendinosus.
here, and then it inserts down here at the medial condyle of the tibia, tibia. And then this rotates like medially as well. And then to help you remember this muscle, it's the most medial of the hamstring muscles, so it's closest to the inside. And then, so to remember the three muscles, I remember the biceps or the biceps femoris, that one's on the very outside. And then to get the two S ones, like to remember those ones, like alphabetically, this one is first, so it's closer to the inside. The next group of muscles we'll talk about here is the gluteus family. So your butt muscles consist of the gluteus maximus, gluteus medius, and gluteus minimus. All three muscles originate from the ilium, so this flat part here, and they all like stack on top of one another, and then their names help you with their placement, like superficial or like deep, like that way. So first we have the gluteus maximus. This is what people usually think of when you say like your butt muscle, like your butt's sore, like this is usually what people are thinking of. So it attaches at your ilium, so this flat part here, and then your coccyx, so your tailbone, and your sacrum, so this bottom section here. And it inserts the fascia lata and the gluteal tuberosity, so this part here of your fibula, and it just goes into your IT band. That. And then for actions, it helps with abduction, extension, and lateral rotation. So then you should know it's just like your butt muscle. A lot of people probably already know this one. And this one is the most superficial of the three. The next is gluteus medius. So its origin is the surface of the ilium. So like this is one that's gonna be higher up. So gluteus maximus was like really high, this one's in the middle, and then the gluteus minimus is gonna be like lower here. And then it inserts on the greater trochanter of the femur, so like this big kind of protrusion here on the top of the bone. And then it helps with abduction, internal and external rotation. And then to help you remember the name medius, like the MED is like medium, like the middle size, so this will be the middle of the three. And then gluteus minimus is the smallest of the three, and it is on, it's like the lowest part of the ilium. And then it inserts like the medius at the greater trochanter of the femur, so this little protrusion here. And then again, it's the same actions, abduction, internal and external rotation. So then minimus is like minimal, the smallest, so it's the smallest of the three. The next two groups of muscles I'm going to talk about like are both, they connect on the origins on the anterior side and then the insertion on the posterior side, so it's a little bit of both. So the deep lateral rotator muscles are the piriformis superior gemellus and the quadratus femoris. And their origin parts are on the anterior side, as I said earlier, of the sacrum, so you can't really see it, but it's on the other side of here. The ischial spine, so right kind of here, and then ischial tuberosity, so a little bit here. And they insert at the greater trochanter like the other ones did, so this you can't really see it, but it's this the higher part here of the femur, this part. And it helps with lateral rotation. And then to help you remember these ones, they all insert or near the greater trochanter, so this big thing here. The next muscle group is the abductor muscles. So as you can probably guess, their action was adduction, so that should be easy to remember for actions. And then for and then all the way down. You can see it attaches inserts there. And adduction, yeah, it's mainly that one. So then the blood supply, okay, so the main artery is the femoral artery. So it's on the, it's most medial, this bigger one here. And the bigger the arteries, like the more important they are, they're gonna be more medial, just like in nature, to like keep it safer, like from like whatever life throws at you, I guess, just to make sure it's safer. It's gonna stay on the inside there, so it can like, so if you like get like hit on the outside or get cut, it's not gonna like kill you, just like hit the little ones. And then there's a lot of little arteries that like separate off, but yeah, the femoral artery is this main one that runs on the inside of your leg. Nerves in the hip joint. The major nerve is the sciatic nerve, this really big one right here. And the nerves that do come out are from, as you can see, L4, L5, and then C1 or S1 through S4. So the sciatic nerve is the really big one that usually gets pinched, but then there are some other smaller ones that come off through there. One of the two common injuries is a labrum tear. Also this, something impingement, I can't really pronounce it, but it's right there. So the two, the things that are important to know about this, I guess, or how to understand it, is the head of your femur sits in this part here of your hip, I forget what it's called, but it sits in there like this, and then it just like rotates. And if it hits against the edge, it can like tear this part here, this like circular part on the outside. As you can see, this little cartoon diagram, this is like the part that's injured, this is very outside the crest. So that's this thing here that you're looking at. And then just like whenever that gets torn, like it happens with repetitive motions, like ice hockey, soccer, anything, like you're moving your hip the same way. So some treatment is like physical therapy if it's like minor, like it doesn't actually solve the problem, but it like helps you from stop hurting for a while. But then like if it's a bigger issue, a lot of times you're just gonna need surgery to go through that, and then therapy after surgery. Just take care of that. And the second thing I was talking about here is the hip dislocation. This happens when the head of the femur is removed from the socket again, like it just like comes out of the socket. It happens with like high impact falls or like high contact sports like football and rugby, where people are like just hitting each other. So it just like flips out. This one you can see is sitting in there, it's chilling, and then this one out here is popped out. So that's not good. So for treatment, if it's not broken, if nothing is like too bad, then they can just give you some drugs, some anesthesia, and just like pop it back in there. But if you break some stuff, then you're gonna need some surgery on that to fix that. So yeah, that's all I had for my slideshow. Should I pull up the worksheet too to show that, or no?
Yeah, let's do it.
Okay. Then I have 2 pages for my worksheet because I couldn't get it to go on the same page. But I just took the main pictures from my slideshow and I labeled them. And then I have like a word bank on the other page, and you can just like figure out if you can remember which muscles go where. So then just like a quick review of these ones. These ones are your gluteus muscles. So the maximus, medius, minimus, biceps femoris, and then the 2 S words, the one that's alphabetically first is C, and then the other one is B. And then adductor muscles, and then these ones, and then your the deep lateral rotator muscles are these ones. And then, so then yeah, I just have this, and you can like write the letter in here if you want for review. And then 2 other questions: what's the name of the major nerve? The sciatic nerve, and then the name of the major artery, the femoral artery. Cute little review. So yeah, that's all I had.
Awesome. Thank you. Okay. I also have Megan's presentation. She couldn't make it because she had work. I've never tried to play a video while on Zoom. But we're going to see what happens.
Good morning, everyone.
So, all right, let's see. Let's just see what I'm made of. Share computer sound. Let's give it a whirl.
Everyone, my name is Megan Markin, and I am a
Can you hear it?
biology student over at Clark University.
Yeah, okay.
I'm sorry I have work this morning, so I can't do this live, and I also don't have a webcam, but my presentation will be over the anterior hip joint. Here are 9 of the important bony landmarks from the anterior pelvis. A major one everyone should pay attention to is the acetabulum. The acetabulum are the 2 indents on both sides of the pelvis, located here and over here. Other landmarks listed on this diagram is the pubis, which is this kind of bridge right here, the anterior inferior iliac spine, which is this kind of point right there, and the pubic symphysis, which is this area right here. Now, onto the femur. So for this presentation, we are only looking at the top half of the femur that interacts with the pelvis bone. First, the femoral head is right here, and this is where the femur joins with the pelvis. There is also the neck, the greater and lesser trochanter, and the intertrochanter line. I wanted to include this slide to show a better view of the insertion happening between the femoral head and the acetabulum to form the hip joint. In order to move the hip joint, there needs to be a muscular system. When being compared to the posterior ligaments, the anterior ligaments are the strongest, but the medial flexors are the weakest in comparison. The anterior hip joint muscles help with activities such as sitting up, kicking a ball, lifting your leg when you climb a ladder, and so on. There are 2 main groups of muscles involved. The first of the 2 groups is the iliopus group. There are 2 muscles in this group, the psoas major and the ilius muscles. The psoas major's origins are the vertebral bodies of T12 through L4. The intervertebral discs between T12 and L4, and the transverse processes of L1 and L5. You can see over on the right where the psoas major muscles are pointed out. For the ilius muscles, the origin is the iliac fossa, and on the right you can see these are also pointed out in the diagram. They both insert at the lesser truncular of the femur and cause thigh and trunk flexions. The ilius muscles are also involved in externally rotating the thigh. The psoas major muscle has a nerve intervention of the anterior rami of the spinous nerves, L1 through L3. The ilius muscles innervate the femoral nerve. The second muscle group of the 2 is the quadriceps femoris group. As you can guess, there are 4 total muscles in this group. The first 2 discussed is the rectus femoris and the vastus intermedius. The rectus femoris has an origin of the anterior inferior iliac spine, and the vastus intermedius has an origin of the anterior surface of the shaft of the femur. You can see over on the right, the rectus femoris is labeled A and it's highlighted in green. Underneath that is the vastus intermediate. It's located on the bottom picture, highlighted in green. The rectus femoris is the only muscle of the 4 that aid in thigh flexion. The other 3, along with the rectus femoris, focus on extension of the knee. So for the next two muscles of the quadriceps femoris group is the vastus lateralis and the vastus medialis. The vastus lateralis is shown as on the top picture over on the right. It's highlighted in green and is kind of more on the outside of the thigh. It has an origin of the linea aspiris and the greater trochanter of the femur. The vastus medialis has an origin of the inner trochanteric line of the femur. It is shown in the bottom picture on the right, highlighted in green, and it is kind of more on the inside of the thigh. All four of these muscles have the same nerve innervation, which is the femoral nerve L2 through L4. And they have the same insertion, which is the tibula tuberosity. When it comes to the regional blood supply, both muscle groups kind of have their own artery that they depend on. The iliolumbar artery helps supply the iliopus group, with some contributions from other arteries, excluding the external iliac and femoral arteries. The quadriceps muscles depend on the profunda femoris artery. This artery also gets help supplying blood from the lateral circumflex humeral artery. Two of the injuries I decided to look at are the iliopus bursitis and osteoarthritis. Osteoarthritis is one of the most common ones you can find when it comes to anterior hip injuries or diseases, whereas iliopus bursitis isn't as popular. Some other popular ones are labial tears and stress fractures to either the femur head or the pelvis bone. But back to the injuries. Iliopus bursitis is inflammation of the bursa between the iliopus muscle and the iliopectineal emergence. Osteoarthritis, as I said before, is one of the most common ones and is mostly found in adults over the age of 50. 40% of the time when a patient comes in complaining about anterior hip pain, it's almost always osteoarthritis. This is just caused by inflammation with the muscles in the anterior hip region. And this concludes my presentation. I would like to thank everyone for listening, and I hope you all have a great day.
Okay. Thanks, Megan, wherever you are out there. Just want to go over a few things related to the lab and the hip and some kind of like little tips that I have to help you remember some stuff. So I'm going to get my deal pulled up here. I have too many things opened. Okay. You guys can hear me?
Yep.
Okay. You see what's going on? Okay. Bony landmarks, again, part of this is I want to make sure that we know how to say these things correctly. Just because, you know, you guys are doing a great job knowing how to identify these bony landmarks and the names of this, but I understand, like, this is a new language. This is like something different that you've never heard of before. But I want to make sure that we can say them correctly, because when you get to PT school or you are a personal trainer or whatever, being able to say them correctly will make you look more professional. So we want to make sure that we're doing that the best we can. Okay, so First, let's start with the femur. Greater trochanter, lesser trochanter, inner trochanteric line, linea aspera. Okay, so those are kind of some of those tougher terms to pronounce. But if you stand up, let's do some palpations to get started. So the first palpation, I'm going to move over to my podium over here. The first palpation I want us to try to get is the greater trochanter. So if you put your hand on, your hips, okay, and then I want you to do just some hip flexion, and I want you to move your hand kind of laterally and feel around. You should feel a bump in there, and you can feel that bump slide as you move. You feel it? Anybody? Yes?
Yeah.
Okay, that's the greater trochanter, okay? Again, like Jess told us, that's a common insertion point for a lot of those posterior hip muscles. The next couple things I want us to palpate. So iliac crest, put your hands on your iliac crest. Yeah, if you kind of put your hands on that posterior side of your hips, that's your iliac crest. Now I want you to follow that over, take your fingers and follow that forward, and you should feel, you guys are all thin and fit, you should feel a little bump here in the front on the top of that iliac crest. And that's the anterior superior iliac spine. You feel it?
Yeah.
Again, for some people it's more pronounced than others, but you should be able to, I think all of you should be able to find that. Anterior, inferior iliac spine, if we were in class, I would have you palpate it on each other, but it requires you to lay down and kind of dig in there. It's harder to get on yourself, especially if you've got a fair amount of musculature in front of that, but that anterior, inferior iliac spine is kind of underneath. Let's see, let's palpate ischial tuberosity as well. So I want you to kind of go back to that position where we're doing some hip flexion. As I do hip flexion, again, if I put my hand kind of on my butt, you should feel that butt bone pretty easily. Again, if you had tight hamstrings, that might be a point of tenderness. But as I kind of come up to hip flexion, I should be able to get a nice palpation on that one as well. So that's ischial tuberosity, or your butt bone. The kind of like the socket portion is pronounced acetabulum, okay? So that's that socket portion where the femur is going to sit inside. Other things to note, one thing I do want to note when we think about the arrangement with the hip is the relationship between the sacrum and the ilium, or this SI joint is sometimes called sacroiliac joint. Very, very sturdy joint. Okay, so there's like a lot of strong ligaments that keep this in place. This joint doesn't move a whole lot, and that's good. We don't need a whole lot of movement in this particular location. I will tell you though, if you like get it inflamed or get it injured, it freaking takes forever to get this fixed because it's so thick in its ligaments. And again, ligaments aren't going to receive as strong of a blood supply in comparison to like muscles. You'd rather have tight muscles than ligaments that are inflamed. I can tell you that. Other things on here. I think I'm good there. One other joint to note, I don't know why this picture is blurry, but the other joint to note here is the pubic symphysis. If you remember back to our unit on joints, anybody remember what type of joint this is? If it's semi-movable, what was that called?
Centroidal.
What's that, Val?
A centroidal, like a.
Yep. So again, pubic symphysis, again, we consider the hips two separate bones, but in reality for all of us, 99% of the time in your world, they're going to function together and they should stay together. The only time this joint really moves is during pregnancy and childbirth. And again, that's going to allow the hips to kind of open up via the release of a hormone called relaxin. But otherwise, they should stay really stable. I've heard of a few, maybe 1 or 2 people having pubic bone stress fractures before. Again, that's a pretty darn rare to see. This should stay really stable for us. This joint should stay pretty darn stable for us as well, especially if we have strong glutes. These hips should work together as kind of a unit and not as 2 separate entities. All right, let's see some movements. Show me hip flexion. Show me some flexion. Okay, so again, I can either have my knee bent or I can have my leg straight. Okay, so that's hip flexion. Show me hip extension. Hip extension is just our standard position. Hip hyperextension is going to be behind us then. Okay, what plane of motion are hip flexion and extension occurring in?
Sagittal.
Sagittal, yep. Show me abduction. Yep, adduction. Okay, what plane of motion for abduction, adduction?
Frontal.
Frontal, good. Show me external rotation. So again, kind of like what we talked about with the shoulder, you can do it in 2 different ways. You can like point your toes out, like 5th position in ballet, I think this is what it is. Or you can, like Val was showing, have your knee raised. Okay, so either one is good for external rotation. Show me internal rotation. Yep, so either like pigeon-toed, or again, you could kind of come across like this. What plane of motion for those rotary movements?
Transverse.
Transverse, very good. That's what those look like. We did them in class. Another thing to think about is this idea of anterior and posterior pelvic tilt. And so again, ideally we want this situation, good posture. Anterior pelvic tilt is really common. Again, especially for those of you that are going on to physical therapy, this is a condition we see a lot of. Now, when you think about this tilting, I want you to imagine like a bucket, right? And if I'm gonna dump my bucket forward or anteriorly, okay, that's kind of what this anterior pelvic tilt looks like. So again, imagine that my hips are the bucket and I wanna dump that bucket forward. I'm going to shift my weight that way, okay? Posterior pelvic tilt is the opposite. So I want to dump my bucket backwards. So if I put my hands on my hips and I kind of shift that weight, that's that posterior pelvic tilt, okay? Can you think of any reason why someone would have, again, I said anterior pelvic tilts is a major concern for us, really super common. Any ideas why? There's really probably 2 good reasons why this is a concern. Both of them have to do with like what we do. That's kind of vague, but. So if my hips are kind of pulled forward like that in this anterior position, what muscles are tight?
Your lower back.
Your lower back is definitely tight. Yep. And then there's one other muscle group. Again, if our hip flexors are attaching on this anterior side, the hip flexors are often very tight as well. What's something that I could do that would make my hip flexors really tight? something that I do a lot right now. That
Sit.
probably, yes, probably all of us are doing a fair amount of, okay? So sedentary lifestyle, sitting, okay? So again, if you have a job where you sit all day, these muscles are going to be chronically tight, right? Because you're in a flexed hip position all the time, okay? So this anterior pelvic tilt can occur from tight hip flexors. That's very common. Again, that might put some pressure on my lower back and cause lower back pain. Lower back pain is one of the major reasons why we miss work. So again, what could I do to take care of this? I could do better to do some stretching. I could do better to get up and move around more frequently and things like that. Posterior pelvic tilt, we don't really see a whole lot of. There's one other reason why I might have this body position. And I want you to think about your center of gravity. There's one other reason why I might have that kind of forward tilt. What am I trying to do? What am I trying to balance? Here's a hint. You're not experiencing this anterior pelvic tilt, but someone like me might be.
When you're pregnant?
Have an anterior pelvic tilt.
When you're pregnant?
Okay, so there's more weight here, right? So center of gravity has shifted. So as a result, I got to kind of throw my shoulders back so that I don't fall forward, right? Not just pregnancy, I could just be obese as well and then have these same issues with balance. So again, a lot of abdominal obesity might put me in this position as well. So again, you think about lower back pain, chiropractors, physical therapists will see a lot of these people coming in with tight hip flexors and too much anterior weight. So again, thinking about those relationships, what's causing this is, I think, really interesting. Lateral pelvic rotation. Again, we talked a little bit about the hip hiker muscle that allowed us to kind of lift the one side. What was that muscle called that we talked about in the trunk unit? That allowed us to have that lateral hip rotation, or yeah, lateral pelvic rotation. Come on, it was in the trunk unit. I called it the hip hiker muscle.
Is it the quadratus lumborum?
Yep, that's correct. Okay, so again, that one kind of connects our core with the hip unit. I think that's kind of cool. All right. So again, if we were to kind of look at muscles based on their location, anterior side, they're going to help with hip flexion. Laterally, they'll do abduction. Posteriorly, they'll help with extension. And then on the medial side, adduction. Okay. Let's see. I want to do sartorius, tensor fascia lata. I think those are the main two that I want to take a look at. Iliopsoas was covered. Rectus femoris was covered. Oh, I know. One thing with iliopsoas, a trick that I kind of have to remember what it does. So again, imagine that I'm a skeleton, right? So here is my muscle. This is going to attach to the anterior side of the ilium. And then the insertion point is on like the lesser trochanter. So it's kind of like wrapping around to the inside of my leg. So again, think about this. We can see that the band is shortening if I do hip flexion. And again, this is one of our strongest hip flexors. It also helps with lateral rotation as well. So again, imagine that I could come up and out. And because that muscle is like diagonal, that's going to help with that lateral rotation piece as well. Okay. Rectus femoris, super strong. Again, as I think it was Megan in her presentation mentioned, a lot of us are super anteriorly dominant, if that makes sense. So like your quads are stronger than your hamstrings. Again, super common for us to have posterior weaknesses. Think about the muscle setup as well, though. I have 4 quads, only 3 hamstrings, so it makes sense that my hamstrings are weaker. So again, that's something that we can think about from an injury perspective as well. What can I do to really activate posterior chain, because I know that it's more likely to be weaker than my quads, for example. Again, bipinnate arrangement with the rectus femoris makes it super strong. Think about how much weight a lot of people can squat, right? Again, a lot of that is coming to with, and again, you're using a lot of muscles with that, but quads are doing a significant amount of work in that particular type of exercise. This is one of my favorite muscles. It's kind of stupid, and it doesn't really do anything like super well, but it does a lot of different things. I guess that's kind of like why I like it, because it like reminds me of me. Like I want to do a bunch of different things. I'm now like expert on one, but I can do a little bit of this, a little bit of that. So its origin is the anterior superior iliac spine, and then it's a strap-like muscle that's going to come across and insert on the medial side of the tibia. The way I remember the 4 actions of this muscle have to do with crossing your legs. So I'm going to show you what that looks like. Oh God. Okay. Let me tip this down a little. All right. So imagine this is my sartorius, and I'm going to activate all those actions when I try to cross my legs. Okay. So right now I have hip flexion. I also have knee flexion. As I go to cross my leg, I'm going to get external rotation and abduction. That's kind of hard for me right now to do. But again, you can see all 4 actions are activated if I try to cross my leg. So hip flexion, knee flexion, external rotation, abduction. So if you can just remember sartorius is crossing your leg muscle, then you should be able to get all 4 of those actions. Yeah, my trick to remember which hamstring muscle goes where is semimembranosus. Has a lot of M's in it, so it's the most medial. And then semitendinosus is the like intermediate, but still on the medial side. And then biceps femoris is the only one that goes to the lateral side onto the fibula. Okay. One trick to remember what the glutes do. Again, I'm a track coach. I'm a track person. And so I always think of this as a hurdler. So I'll do my best to demo. If Sia was still on, she would be able to demo. Is she still on? You're there. Yeah, you're in there. I couldn't see you on my screen. She could demo some hurdle drills for us. I'll do my pregnancy best here for you. So when I do a hurdle, and again, maybe this is helpful for you, maybe it isn't. When I do a hurdle, again, one leg is going to come over. This is my lead leg. That's the first leg that's coming over. Then I also have a trail leg. Okay, so my lead leg comes over first, and then my trail leg is coming over second. Okay, so when I do my trail leg, I activate all 3 of the glute max actions. Okay, so again, imagine that I went over with my lead leg, which would never be my left, but in this scenario, I will use my left. Okay, so I go over the hurdle with this leg. Now I'm going to do extension, external rotation, and abduction in order to get my trail leg over the hurdle. I'm out of breath and I can't really demo that as well as I normally can. What the heck? I needed you, Sia. So again, if that's helpful for you, if you can remember hurdles and the glute max, we'll use those 3 actions. Great. If not, forget it. Glute med, again, check out, it's kind of like a radiate arrangement. So again, you can see the fibers are kind of spread out at the top and then have that common insertion point on the greater trochanter. Strong abductor for us. Glute minimus, also kind of a radiate arrangement. Can help with medial rotation. You might see that it helps with lateral rotation as well. Same with glute medius. Some books will say it helps with internal and external rotation. That's totally fine. You can include those. Tensor fascia lata, everyone's favorite coffee muscle, right? Again, this one's freaking annoying. This one, if you get it tight, it's freaking hard. The reason that it kind of sucks is because look how small this muscle is. It's this tiny little thing. And then we have this huge band here, okay? This huge ligamentous band known as the iliotibial band or the IT band, okay? The reason that this sucks when you get it tight is this band is super hard to stretch out. If it's a tight muscle, no problem. We can stretch a muscle. Muscles are very elastic and we can take care of that pretty darn quick. But if you get this muscle tight, it's really difficult to get this thing stretched out, okay? So the actions that it does, certainly abduction because it's located on the lateral side of the hip, also slight hip flexion and also a little bit of internal rotation as well, okay? Again, if I were to get a tight IT band, a lot of times this will present as lateral knee pain, super common in distance runners. But it'll present as like knee pain on the lateral side. And really what you have to do to loosen this up is like a bunch of foam rolling and stretching up here in both the glute and the tensor fascia lata in order to like get that taken care of. It's like the one annoying injury that I tend to get because I never stretch. Yeah, I just covered these, the deep lateral rotators. Again, they'll help with hip external rotation. They're also great stabilizers for us as well. So, okay. Questions on any of that? I know I went kind of fast, but everybody's okay? Okay. So, the other thing I wanted to do today is the lower extremity PowerPoint unit. And again, we'll kind of go through this the same way we did with the upper extremity. Again, there's basically just some charts that we're going to fill in that'll give us some review on the hip, but also give us a preview of things that we're going to cover with the knee and the ankle as well. Okay. So again, we think about strength of the lower extremity. We know that this is super important for body maintenance, balance, and posture. Again, when we think about the division of lower limbs, we can divide these up based on compartment. Again, the anterior hip will allow us hip flexion. Anterior compartment of the knee will help us with knee extension. Anterior compartment of the lower leg will do dorsiflexion of the foot. And then, you know, the posterior side will do those opposite actions. Laterally, abduction, again, that's only going to be hip. And then medially, that's going to be adduction of the hip only. Okay. Show me dorsiflexion of the foot. I can't see anybody's feet there. I can see Jess. Yep, toes are up. Yep. Show me plantar flexion. Yep, toes are pointed down. Which plane of motion for dorsiplantar flexion? You guys are all muted.
Sagittal.
Sagittal, excellent. Okay, pelvic girdle, we just went over those. We did that. Okay, so instead of breaking you into groups, because there's only a small amount of you with us today, why don't you guys do this together? So again, a lot of these we covered today. So go through and let's fill in the posterior hip muscles, which muscles do which actions. Okay, so I'll give you some time to work on this together. Okay, ready to go.
Gluteus max. extension. Abduction. Lateral rotation.
The gluteus minimus and medius both do both rotations.
And then
And
the gluteus medius does abduction, abduction.
yeah, they both do abduction, yeah.
Mhm.
Or so like those next three are they?
Do they do flexion and extension?
Yeah. And
Maybe. Um,
and then that next one is part of the
would that be like they would do abduction? They would like move the leg. Or
which
How you guys doing?
around the semimembranosus, we're figuring it out.
I think that those just do abductions.
Both of them.
Yeah.
And then for the last one, I found that it does lateral rotation and then abduction as well. It's just what I found. I don't know.
Sounds about right. Yeah, because it's one of the adductor muscles.
You guys got them all?
I think so.
All right, glute max, what do you got?
Yeah. Hip extension, lateral rotation, and then abduction, I think is what we said.
Look at me, look at this. New skill I just figured out. An abduction, right?
Yeah.
Okay, minimus. Next one, what'd you have?
Abduction.
Yep. Medius.
Abduction.
And again, if you chose medial or lateral rotation for either of those, that's totally fine. That you would find that in some sources. Okay. Biceps femoris, again, we're only looking at the hip. What's it do at the hip? It's a posterior muscle.
Abduction. Right?
Biceps femoris?
No.
It's one of the hamstrings.
Yeah.
Extension.
Extension?
Yeah.
Semimembranosus?
Extension.
Semitendinosus?
Extension.
Which was the most medial of the hamstrings?
The middle one with all the M's.
One.
Yep, membranosus, thank you. And piriformis, what's he gonna do?
Adduction.
Adduction? AD?
Abduction.
AD?
Yeah.
Okay, I'll buy it. Okay, what else?
Lateral rotation.
Okay. Probably more lateral rotation than adduction, but whatever, I'll give it to you. Okay, neat. Look at me, I'm so excited. Now I don't know how to go to the next slide though. Come on. Oh, now they're gonna stay there? What the hell? These are some neat pictures that could be on an exam. Okay, now we're on to anterior. And let's see if I can clear. Oh, come on. Anyway, you start working on this. I'll worry about how to get it cleared out. There we go. All right, same deal.
For the first one, I found have hip flexion and then lateral flexion. I guess that doesn't really. I don't know.
What'd you have? I didn't even.
I had flexion of the hip and then lateral flexion of the hip.
And would the next one have abduction too?
Yeah.
And then also it said, wait, flexion and slight hip internal rotation as well.
Yeah.
The third one, is that the long one that goes, the sitting, the crossing the leg one?
I think so.
Would that be like adduction? And
And then
For that one, I think it's also external rotation and then flexion of the hip and knee as well. And then for the rectus femoris, I have hip flexion and knee extension.
I don't really know about the one with the V one, the vastus, but the adductor muscles, I know they rotate, or they adduct thigh and then they rotate medially. See those?
You guys ready? Yeah? Ilios, and again, just focus on what's going on at the hip. What's iliopsoas doing? Flexion, I heard. And what was that, Luis?
Lateral rotation.
You got it. Okay, TFL. Tensor fascial lata.
Abduction, flexion, and then a little bit of internal rotation or medial rotation.
Yep. So its main job, if I had to choose one, would be abduction, but it does slight flexion and also does slight medial rotation. All right, sartorius, and again, remember, just focus on what's going on at the hip, and then we'll hit with the knee here in a little bit.
So flexion,
Yep.
lateral rotation, and abduction.
Again, he's not really like a major player in any of those. He's just an assister muscle because he is small and strap-like. All right, rectus femoris.
Flexion.
Yep, hip flexion. That one's biarticular. Vastus muscles. These are your other quads. This was a trick. They don't cross the hip. Those start on the femur and cross the knee. They're commonly confused as hip, hip flexors. So a lot of times they're put into the same category, but these three quad muscles with the vastus word, those are only going to be knee extensors. So those don't do anything with the hip itself. Okay. And then adductors do what they tell you.
Adduction, and then a little bit of medial rotation.
Sure. Good. Okay. All right, so now onto the knee. Again, the knee is not a hinge joint. I would like it to be because it makes me feel more comfortable. I don't like when it rotates. It primarily does flexion and extension. It can also do medial lateral rotation. For our purposes, we'll just stick with flexion and extension. Okay. Again, the nice thing about this, if you kind of compare it to what we see in the elbow, if I'm on the anterior side, I do one action. If I'm on the posterior side, I do the other action. Okay. So I'll give you some time to get this one figured out.
All right, so the first three I know are on the posterior side. I don't know about the fourth one, and then the last three are on the anterior side. So the ones on the back,
That's extension.
extension, and then the top three extension, bottom three flexion, and I don't know about the G one. I don't know where that's at.
It would be like flexing, I think flexing like ankle and the leg.
Yeah, that's what I found too.
You guys done? Sorry, I was reading an email. Yeah, all right. Okay, hamstrings. These top three. What do they do at the knee?
Extension. Or
Not at the knee. The knee is like backwards, I feel like, compared to the elbow, if that makes sense. Oops.
be flexion.
Yeah, so the hamstrings are going to do knee flexion. Okay, so knee flexion is like the same as like a leg curl, right? This is knee flexion. This is knee extension. Again, it's backwards from what we do in the elbow. In the elbow, this is flexion, this is extension. So the knee is kind of like backwards comparatively. All right, sartorius. Oh, I skipped one. Sorry, gastrocnemius.
Flexion.
Yep, it's also a posterior muscle. It's a lower leg muscle. And sartorius.
Extension. Or flexion.
Cross your leg. We got to have a little bit of flexion.
Flexion.
Yep. Okay, vastus. Those are your quads.
Extension.
Yep. Rectus femoris.
Extension.
Yep, also a quad. Good. So we talked about dorsiflexion, plantar flexion. Now inversion, eversion, what plane of motion? Again, you can see those down here. I'll figure out how to get rid of my pictures. Inversion, eversion, what plane of motion is this? Look, I can do that.
Transverse.
It's actually not. It's actually just imagine like sliding your weight from the inside of your foot to the outside of your foot. This one's very tricky.
Frontal.
Yeah, it is frontal. This is a weird motion. It's more of a foot position than like an actual motion, okay? So if I'm inverted a lot, that means I have like a high arch. If I'm everted a lot, that means I'm more like flat-footed, if that makes sense. So again, it's not necessarily, like we don't really think of it as a movement. However, it's more of like a position, I guess. Toe flexion, toe extension, which plane of motion for those two?
Sagittal.
Sagittal.
Good. Okay. One thing that's unique about the lower leg is we have 4 different compartments. And again, we'll talk about those, I think it must be next Wednesday. Those 4 different compartments are covered by this thick connective tissue covering, like a sheath, basically. Like, so imagine, like, you know, when you buy like the summer sausage at the grocery store and it's in like that little plastic casing, you know what I'm talking about? That's like super thick and it doesn't really stretch, and you have to like cut the meat out of the casing that it comes in, that wrapper. Okay, that's kind of what these compartments are like. So again, they're not really super giving. They're pretty darn tight, which can become an issue for us if we get inflammation in this area because they don't give at all. Any idea why these compartments are good though? Like, what purpose do they serve? If I'm saying they're bad if we get injured, they don't allow us to really swell. Why are they good? Any ideas? Think about where they're located. Again, they're in your lower leg.
Stability.
Okay, so they're going to give us some stability. Absolutely. Okay. Think about like blood flow to your feet. Okay. Someone tall like Jess, for example. How much gravity do your vessels have to overcome in order to get that blood all the way from the bottom of your feet all the way back up to your heart? Like a lot. So imagine somebody who's like, 6'6" or something like that, right? Like that's a lot of gravity to overcome. So these allow us to have some pressure in those lower limbs that allow us to get that blood back up to our heart efficiently. That's kind of what their purpose is. Here's some lower limb musculature. Again, gastrocnemius, soleus, those are our 2 major plantar flexors. Tib anterior is another strong dorsiflexor that's pretty pronounced. So that, like, if you get shin splints or if you've ever had shin splints, a lot of times it's tib anterior is the muscle that's affected by that. So that's a strong dorsiflexor. In general, the musculature is kind of set up similar in the foot as what we see in the hand, which is nice. Alrighty, so these are all new to you, I believe, but let me give you some time to see if we can figure these out. All right.
For the first one, I found that it helps with plantar flexion, but I don't know if it does anything else too.
I think the first two do plantar flexion.
Okay.
The third one, I'm gonna guess it does toe flexion because
Yeah, it is.
flexor and like digit. So I don't know if it does anything else though.
Might help with plantar flexion too.
For the tibialis posterior, it helps with inversion, and it also does plantar flexion.
So then the tibialis anterior probably does the opposite of them, and then so then dorsiflexion and then
Eversion.
eversion, yeah. And the one after that probably is toe extension because extensor and digit.
And but after that, I found it does like plantar flexion and eversion.
Yeah.
We got them all? Yeah? Okay. All right. Tell me, gastroc.
Plantar flexion.
Yep. Okay. Soleus.
Plantar flexion.
Flexor digitorum longus.
Toe flexion.
Yeah. Anything else? Or that was all you had on that one?
We thought maybe plantar flexion, but mostly toe flexion.
I think it probably assists in this. Tib posterior.
Plantar flexion and inversion.
Yep. Tib anterior.
Eversion and dorsiflexion.
Extensor digitorum longus.
Toe extension.
Anything else? So it's kind of the opposite of this one.
Dorsiflexion.
Yeah, would help a little with dorsiflexion. Okay. And then fibularis longus and fibularis brevis, also known as peroneus longus and peroneus brevis. Sometimes seen.
Plantar flexion and eversion.
Yep. Good. Okay. Let's clear those out. Again, when we think about lower extremity functioning, certainly essential in our everyday life. Also important to note when we compare and contrast to upper extremity, our force production of lower extremity musculature is significantly greater than that of our upper body, just simply from the task of carrying our body weight around. So again, our lower extremities must be significantly stronger than that of the upper body. Okay. Remember those terms closed chain and open chain? I want us to kind of brainstorm now, some examples of closed chain or open chain exercise for the lower extremity. So if somebody could remind me what the difference was, then we can kind of have a good brainstorm here on which ones do, you know, what exercises fit into which category. What do you remember about these?
One of them is where you manipulate yourself around like an object or like the ground or whatever. And then one of them's like free weights, kind of.
Yep. So one of them, we're manipulating our body around a fixed point, and the other one, we're manipulating our extremities while keeping our body stable, basically. Now, the question is which one is which?
Closed is with manipulating a surface, your body around the surface.
Yes. Yep. An open chain is moving a distal extremity. Okay. So let's think of some lower extremity. Let's start with open chain. So again, if I manipulate my distal portion, so again, probably going to have to be your legs in this scenario, while keeping our core tight, what are some examples of open chain exercise for lower extremity? Again, for upper extremity, we had like bicep curls, shoulder press. Those were a couple examples.
Leg lifts.
Okay, so a leg lift, sure. Like where you lay on your back and bring your legs straight up. Is that what you're thinking, Val? Yep. Yep.
Mm-hmm.
How about like two more things? This one's a little tougher. Think about things in the weight room.
Would squats work?
Squats are going to be the other ones, because squats, you're manipulating your body against the ground, serves as that stable surface.
Flutter kicks.
Okay, flutter kicks. Yep. Again, maybe not an exercise that any of you do, but like the leg curl machine or the leg extension machine. Again, I'm manipulating, or I'm trying to move my feet basically against a weight, if that makes sense. Like, so on the upper level of the AWC, you know which machines I'm talking about? Yeah, so those are examples of open chain. But again, it's hard to think of open chain things that we do for lower extremity, because most of the things that we do for lower extremity are closed. Okay, so squats, what else?
Deadlifts.
Deadlifts, yep.
Lunges.
Lunges, yep. Squat jumps. Okay, so again, all of those things, I'm using the ground as a stable surface, and I'm manipulating my body, my entire body, against that surface. So again, one major difference when we look at exercise in lower versus upper extremity is we're using a lot more closed chain for lower extremity in comparison to upper extremity. Oh, this I just enjoy. So, one other thing that's important to note when we think about quad movement is the eccentric contractions or the eccentric load that our quads must overcome in various scenarios. So, again, when we think about deceleration, and again, a lot of, we spend a lot of time thinking about how to accelerate, how to become faster, how to move efficiently, change direction and things like that. But part of being able to be able to change direction has to be deceleration. We have to slow down so that we can shift our weight in a different direction. And so we have to have this great amount of eccentric strength in our quads. Okay, so when our body slowly lowers in a weight bearing movement through lower extremity action. So again, deceleration involves this kind of braking motion of the quads, which is super important. Again, I'll try not to get too much into it before you take strength and conditioning, but this eccentric contraction that we see with the quads is one of the keys to being a multi-directional athlete. So being able to train people to change direction quickly, you have to have this eccentric force. You have to be able to eccentrically contract in order to stop one motion and, move your momentum in a different way. So that's an important part to train. I love this. We think about the overload principle. And again, how do we stress a muscle? How do we build a muscle stronger than what it was the day before? Okay, so we have to use something known as the overload principle or progressive overload. And so essentially what we're looking at here is if I only do this, that's as strong as I'm ever going to be. If I continue to just stay at that level and continue to lift like 55 pounds or whatever it is, my body is so efficient that it will only do the amount of work it needs to do in order to do whatever I ask it to do. Okay. So again, with overload, I have to continually find a way to progress. Okay. I have to lift more weights, or I have to do more reps, right? Or I have to shorten the rest interval. I have to do more sets. I have to do something so that the next time I do this, it's harder. It's more of a stressor than what it was the first time. Okay. And that's what progressive overload is. If we don't progressively overload ourselves, we're not going to get better. Okay, so again, the idea with this is we want to do it smart. Like we don't want to freaking, I lifted 55 and now I'm going to go 100 and see if I don't, tear a labrum or something like that. Like we don't want to do that. We want to do it in a, a logical way. But if we don't continue to overload ourselves appropriately, we'll never get better. Right. And I don't know of any athlete or, I hope I don't know of any people that are like, you know what, I just want to be the same as what I was last year. Like that was fun. I'm just going to kind of hope that I do about that same thing. No, I want to freaking get better every time. Right. Like otherwise we're wasting our time. So again, this idea of progressive overload is important. And I think it's really neat. All right. Now, that being said, progressive overload is really neat and everything, and we want to reach this kind of optimal level of training. However, we also know that doing too much is bad, right? So, well, that's confusing. That's annoying, right? How do I know when too much is too much? Well, you don't. That's the trick. That's the art of being a cognizant athlete or being a cognizant coach, is understanding when something is too much for one person, but someone else might be able to handle that same exact load, that same exact work, right? So if I'm doing too much, that will actually decrease my performance through a component known as overtraining. Okay, so again, total stress, we've got to find this sweet spot in the middle. And what is unique and what is really, I think the art of coaching is understanding how to find that for each person and how that's different for each of us. Okay. Oh, I kind of already answered this. How do we overload the body? Again, you've got to find a way to do something more each day, right? So again, we think about overload as it applies to running, for example, okay? So let's say like this morning I ran 1 hour and I ran 5.8 miles in that hour. Okay, so what could I do more tomorrow to overload my body? What could I do to make it harder tomorrow? What are some examples? There's like 5 different things.
Run for 65 minutes.
Okay, I could go the same pace, but go a little bit further, increase the duration to 65 minutes. Okay, what else?
You could pick up the pace.
Okay, so instead of running 10:30 per mile pace, maybe I run 10-minute pace. So I'm going to run a little bit faster. Okay, what else could I do? Probably like 2 more things.
Change your incline.
Okay, I could go up a hill instead of just running on the flat heritage trail. Okay, yep. Change the surface, make the surface more challenging. One more thing I could do.
Would altitude be in that same, or is that separate?
Yeah, that would definitely stress my body more. Sure, I could go to altitude. Yep. Okay, one more. Or think about over a week, not just one day. Maybe that would help you. Maybe I've been doing 3 days a week, 1 hour, 3 days a week. What could I do next week that would be different?
Do it like more often, like more days of the week.
Yeah. So I could go 4 times next week, or 5, or something along those lines. Okay. So we can add frequency as well. Again, I like to use running as an example because that's easy for people to kind of conceptualize, but this applies to the weight room as well, right? So again, if I wanted to get stronger in the weight room, instead of lifting 55 pounds, maybe I bump it up to 60. Maybe I do more reps. Maybe I do more sets. Maybe I add another workout each week. Okay. So there's lots of ways that we can continue to overload the body. That's the art, though, is figuring out which way is the best way for that individual person, right? Well, it depends on their goals. If my goal is to be really fast at running a 5K and I'm running like an hour each time, well, maybe I need to increase my speed. I need to pick it up a little. I don't necessarily need to do more volume, but I need to run faster. Okay, so again, we've got to think about the goals of that individual in order to know what's the appropriate overload for that particular person. Oh, common injuries associated with lower extremity. Again, all 3 of you are athletes. Let's hear the lower extremity injuries we have as a group. I'll let you start because you know that I believe that injuries are all mental, so I don't have any injuries. Jess, what do you got?
Rolling your ankle like too much and then overextending it.
Okay. Sia?
Stress fracture,
Stress fractures? Val?
like IT band syndrome.
Yeah, that one's annoying. Okay. Again, with us putting more, I guess, stress on the lower extremity because it has to carry more, it carries our weight, right? And then you add, so much stress in a good way when you do something like jump or run, right? 3 times your body weight, that's a huge impact on us. So again, the risk of injuries associated with the lower extremity is just pretty darn high, especially compared to that of what we see in the upper extremities. All right. Questions, concerns, comments, anything? All right. Happy Friday. Let's see. We only have 2 more Zoom sessions. Okay. So we'll have the knee on Monday and ankle and foot on Wednesday. Then you take your lab practical on Friday, right? Yeah.
I have the question that I texted you about for our test, our live practical.
Yeah.
That wasn't like an answer to pick from.
Wait, which one is this?
The trapezium, the bone that was right under the thumb.
Yeah, I
B,
was wondering that
because I was
too.
looking, because I took a picture of the screen to show you, because it wasn't an option.
I
like-
took that too, actually.
Because it had,
It showed up on mine, like,
because, no, like, I don't know if you can see my screen, but those were the options, and trapezium wasn't an option. So I just like picked a random and
I
asked
just-
on there.
Yeah, I had that same question.
So then I got really confused if my notes were all wrong or if because it wasn't an option to pick from.
Yeah, I have it too. I just didn't see that.
That's why I texted you and I was like, maybe she doesn't realize it, but yeah, I wasn't an option to pick from, so I was kind of confused.
okay, let me
That's
go
why
back.
I texted you.
Let me go back and look at it, because again, I thought it showed up fine on my end,
Okay.
but I'll go back. I'll go back and look at that today. So, okay. Anything else? You guys are all frozen now. Anything?